Hello and welcome to yet another episode of Health DNA. I am Nivedita Das. Old or young, professional or non-professional, almost every individual nowadays are complaining about joint pains, and a few are also opting for joint replacement surgery. To talk about the topic, I have with me Dr. Gurpal Singh, who is with Mount Elizabeth Novena Hospital and Parkway East Hospital, Singapore. Welcome, Doctor, to India TV Digital.
Thank you.
I want to start by asking, how common are you facing this issue of joint pains? How often are the complaints of joint pains among patients?
Well, it is so common that nowadays, if you're sitting in an audience or if I'm giving a talk, I sometimes ask the question, rather than saying who has faced joint pains, I ask who has never faced joint pains.
Yeah.
So usually, if you're lucky, you will have one hand in the audience. But I think it's like we say in Hindi, ghar ghar ki kahani. It's in every house, back pain, knee pain, hip pain. I'm sure you have had it.
Yeah. I think every person who is having a sitting job of a 9 to 5 job is often facing this joint pain.
Yeah, I've had my fair share too. So I think this is very common. And if we want to hazard a guess, if you combine all joint pains, you'll be looking at more than 70 to 80% of the population. The older folks will be, you'll be looking at more degenerative type of disorders. The younger people would be more sports injuries. And there are about 5 to 10% of people who have joint pains from more serious problems such as infections or cancer.
Okay.
And that is the scary part, is that that number is growing.
Okay. So these joint pains are often the reason for joint replacement surgeries?
That's right. So joint replacement surgeries are usually a last resort.
Okay.
When you have, when the patient develops end-stage arthritis, which basically means that the cartilage that is lining the joint surface is worn out completely, and the bones are starting to grind against each other, and quality of life is diminished, all other options have failed, then we discuss joint replacement surgery.
Okay, so
it's not the first resort.
Okay, this is not the first resort that you are saying. No. So nowadays, like, there is a common problem, like a person is sitting and all of a sudden that person says that there is some cracking sound coming from my knee.
Yeah.
So is this related to joint pain or some very major issue is coming up?
So cracking sounds in the knee are very common. Certainly we don't do joint replacements for cracking sounds. It needs to be a lot more severe than that. If it is painless and it's an occasional thing that happens, there's usually nothing too much to worry about. But the problems, usually when there is pain, swelling, deformity, that means the leg has started to become a bit bowed, then we worry. And if there are what we call red flags or warning signs, like if there is pain at rest, if there is pain at night that disturbs sleep, loss of weight for whatever reason, unexplained fever, then those are what we call red flags or warning signs that this may be something a bit more serious than even arthritis. Yeah.
Okay, so is this only specific to legs?
No, it can happen in any joint. So when we talk about legs, essentially the common joints that are affected would be the knees, following which would be hips. Ankles, yes, but less so than the knees and hips. But you get the same problems in the ankles as well as the smaller joints in the foot. You can get the same problems in the shoulder and the elbow as well as the wrist and the hand. But the lower limb joints tend to get a bit more affected because those are the weight-bearing joints. But that's not always the case. You can get similar issues even in the spine. So arthritis or wear and tear can happen at any joint in the body. And yeah.
So you just mentioned, because this is very new, that there may be some problem with the spine as well.
Yes.
So please tell us more about it.
So a lot of people would have experienced back pain. I think the terms slip disc, nerve impingement, and in the older years, we have seen people with deformity, with back pain, numbness of the legs. So essentially what I was trying to say is that the process of arthritis or wear and tear, if I were to say osteoarthritis, now these are just names and terms. It's beyond the scope of today, I guess, to go into the details of what types of arthritis there are. But for today, we will just say that arthritis equals wear and tear, and simplistically. And this wear and tear basically means that the lining of the joint wears out, and then you get the bone surfaces grinding against each other. And this can happen at any joint in the body. So when we say knees and hips, it's because these are things we hear commonly. But the same thing can happen in upper limb joints, less commonly because they're non-weight bearing. And the same thing can happen at joints in the spine known as facet joints, where the vertebral bones are sort of, joining with each other. And the same process can happen there too. So when we say wear and tear, it's not one joint in the body. We have to look at the individual holistically and realize that if that person comes with knee pain or hip pain at an older age, one should also look at the spine and look at where is there any coexisting problem, so to speak, because often it's not just in one joint.
Okay.
Yeah.
So when a patient comes with, let's say, back pain, or how is it? I am just, as a lay person, I just want to understand how hip pain is little different from slip disc. How do you differentiate? What exactly is slip disc problem?
So you need about 5 years of medical school plus 10 years of training as an orthopedic surgeon for me to tell you that. Okay. But trying to put it in simpler terms. So we try to distinguish pain that by its origin.
Okay.
So often the misconception that people have is that pain that's around the buttock region, somewhere there, the buttock area, and that goes down the back of the thigh, is hip related. Most commonly it is coming from the lower spine, where there's either a nerve impingement of some sort or something. Hip related pain, where true ball and socket hip joint related pain, tends to happen in the groin, front of the thigh, side of the thigh. So that clinically, when we examine, if it's hip related, we might find that hip movements will elicit the pain, or hip movements may be limited, versus if it's coming from the spine, clinical examination involves certain maneuvers such as doing a straight leg raise, doing certain other tests that you can do to in what we call nerve root tension signs. We can increase the stress of that, or sort of kind of pull that nerve a little bit more to see whether that is causing an increase in pain. And if so, then that points towards a spinal origin of the pain. So taking a history from the patient, doing a physical examination, these are the basic things that should never be overlooked. And then only we proceed to imaging investigations, which are usually in the form of plain X-rays as well as MRI scans.
Okay. So what kind of maximum joint replacement surgery patients are you getting from India?
Maximum joint replacement, are you referring to the joint, or are you referring to...
I mean, is it hip replacement or...
No, the vast majority of joint replacement patients that come from India are knee replacements.
Knee replacements.
Knee replacements, yes.
Okay. So what basically, according to you, are the reasons for this knee replacement, or why only so many cases of knee replacement is coming from India?
So I think it's not only from India, it's a worldwide problem. But interestingly, in Western countries, we see a lot more hips, like in Europe and in the West. In Asia, we see a lot more knee-related problems. There are a lot of theories for this. One of the theories is that if we look at, say, a generation ago, there was squatting posture was quite prevalent among our cultural habits and day-to-day, whereas the Western population never really was adopting squatting habits, so to speak. So one of the theories is that squatting kind of has protected our hips but damaged our knees more, but this is only a theory, so it's not proven.
Okay.
There are other postulated theories to that as well, but frankly speaking, it's not such a productive exercise to, I mean, it's good to know. Of course, at some point we hope that, you know, arthritis can be prevented. Where we are going now in terms of treating these problems is we are moving towards, you know, newer technologies in terms of treating arthritis. Joint replacement is taking on, you know, a very customized, individualized, you know, role with with robotics being available. Now, essentially, it's a bit like a nice analogy is if you go to a tailor and get a dress made versus you buy a ready-made dress. There's a difference, and I'm sure I already see a smile on your face when I said that. So I'm sure you've had the experience where you buy something ready-made and you're in between two sizes and you're not too happy with it. So in that same sense, joint replacement is not a one-size-fits-all option. We are having a large number of patients now who are younger, who are in their 50s, who have been very active in sports, and their joints have sort of burnt out at a much earlier age than they otherwise would. And they still want to be active, they still want to continue being very active, and they need a joint replacement. Now, that joint replacement is very different in nature from someone who is, say, in the late 70s, 80s, more sedentary, has osteoporosis, meaning some hollowing of the bone. So the two operations are very different. They're very different. So what we are moving towards is a understanding of the patient. For example, if someone's an avid cyclist, like I have a patient I've operated on recently. He's in his early 50s. He's an avid cyclist. He had end-stage arthritis of his knees. He's got 2 joint replacements now, and he's still cycling 140 kilometers a week. Of course, you know, I wasn't too happy with that, and I told him, you're going to wear out these knees in no time, but he said, this is why I did it. So this increasing, you know, trend in, you know, that we are seeing the younger arthritics, we call it, and they're very active, but their joints are giving way, failing, because they have been either had injuries when they were younger, or they were triathletes, or, you know, very active sports people. So when their joints fail, they are going, and if they need a joint replacement, they will put that new knee through a lot of quote-unquote abuse, because that new knee, they are going to be very active with that new knee. So it's better that we know what they want to do, and then we can have, you know, a two-way conversation on what you can expect and what you can do and how can we help you with that.
Okay.
For example, an avid yoga practitioner may want to sit cross-legged. Is it impossible with the knee replacement? No, it's not impossible. Is it impossible to cycle 140 kilometers with 2 knee replacements? No, it's not impossible. But do we recommend that you jump and you do skipping and running? No, we don't recommend that. So essentially the 2 things you can't do after a knee replacement are jumping and running on that knee, which would cause impact on that new knee replacement, and a very deep squat. We don't recommend that. But short of that, most boundaries can be pushed nowadays. But it's a good idea that your orthopedic surgeon knows what your needs are. So that's where the conversation starts. The start of this so-called tailor-made or customized medicine is a conversation with your orthopedic surgeon on what your needs are, so that can be translated into a plan, not just for surgery, but for rehabilitation as well. Now, rehabilitation does not start after surgery. Rehabilitation starts before surgery. Prehabilitation, we call it, starts way before surgery. Your physiotherapist should know you, and the physiotherapist and the doctor should communicate, and you have a tailor-made plan that this patient has got this problem. These are the needs of the patient. Now let's start working on the muscles. If the muscles are in good shape, it's a higher likelihood that the patient will do better after knee replacement. Then that chemistry between the physiotherapist and the patient and the surgeon takes that patient on a journey with a lot more ease. During surgery, if we know the specifics about the patient, meaning what the patient needs or wants to do, short of what we tell the patient not to do, if we know that, we can adjust certain techniques to provide for more flexion, or and so on and so forth. We also make certain adjustments with regards to quality of the bone, severe muscle stiffness, and so on and so forth during surgery. Robotics helps in the sense that it's a tool for precision. And I'll just illustrate that with a little analogy here. If you take this device or a mobile phone and I put it on a flat surface like that, and if I ask you, can you give me 30 degrees? Are you able to tell me precisely where's 30 degrees?
Okay. No,
You can't, isn't it? I don't think there's any human being in the world who can do that.
Yeah.
So why is a surgeon so special, So this is an inherent limitation in our senses. So robotics basically takes the game of precision to a whole new level. So if I need a cut at a certain degree, say for the socket of the hip, if I need to put it at 35 degrees, I can do a CT scan, know that the patient's native socket is like this, and I can then plan the socket to be at 35 degrees for that patient, because no two patients are the same. And during surgery, I can see that on a screen, and it gives me that precision. I'm no longer guessing. And there's no estimation, I'm not guessing. And if I'm not there, the robot won't let me put that cup in. It's like hitting an imaginary wall. So robotics is not a fashion statement. It's not something that we sell for purely marketing purposes. It's nothing of that sort, although I see it sometimes going in that direction. It's something that enhances precision.
Okay,
because
so, when you're saying this robotics, so where do you see the future? Do you see a future for robotics?
Oh yes, we are already doing it. It's already like 90% of my knee replacements are robotic assisted joint replacements.
Okay.
We are already doing it.
Okay.
It's already there.
Okay.
It's that the future will probably be, AI enhanced and all that, but that's something which is, we don't, it's a bit beyond for today, the scope of today, but robotics is not something that is a wish list for the future. It's already there now. It's already there. It's a tool that allows us to deliver precision and customized, a plan that we have for that patient. So post-surgery, robotics also allows us to, the trauma to tissues, the amount of muscle we need to cut is all, less. And post-surgery pain management techniques have evolved.
Yeah.
So, it's nowadays after a knee replacement, if you've done the replacement in the morning, in the evening when you go to the ward, the patient will be comfortable having dinner and smiling at you, having a decent conversation with you. And that's because we use what we call nerve block injections, we basically give an injection along the major nerves of the leg, so that for the next, say, 2 days, 3 days, there's controlled delivery of medicine along the nerve, which reduces the need for morphine and opioids and all the horrible medicine that cause nausea, vomiting, and all the unpleasant things after surgery. Pain is well controlled, and normally we walk the patient either same evening or the next day, and we normally say, okay, about 3 days in hospital, and then the patient goes home. Patient's walking with a walking frame for about 2 weeks, and then on a walking stick for another 2 weeks, and at 1 month we want the patient to be independent. So this is different from, let's say when I was training, because then we would be talking like 6 months. And the difference is because techniques have become better, more individualized, technology has become better, more precise, and pain management techniques have become better. So yeah, that's where we are today, and I think we'll continue to get better.
Yeah. So when we are talking about any replacement surgery, so is there any timeline that within this much period of time that patient is going to be absolutely fine, he or she is going to be like before?
See, there are no guarantees in medicine. There's only one person who can give you a guarantee, and you can call him any name. He is certainly not a human being. Now, short of that entity or that person, no one can give you a guarantee. So we can give you milestones. Everybody has different, depending on the severity of arthritis and depending upon how tight your muscles are and how good is your stamina, how good is your heart function, how motivated that individual is. All these factors contribute to rehab after surgery. So what we have in terms of the timelines that we would say exactly, what we discussed. So surgery today, on your feet tomorrow, no bed rest. Bed rest is not to be discussed. You're on your feet tomorrow, 2 weeks you're going to be on a walking frame, then you're going to be using a walking stick, and then you're independent after 1 month. So we want patients to achieve these timelines, and we push them quite a lot. Some people are more motivated, some people are less motivated. Culturally, we discourage, the presence of a lot of people, help. There's a concept that after knee replacement, I'm going to need a lot of help.
This you are talking about physiotherapy?
No, I'm talking about family support.
Okay.
So the more independent an individual is, the better the outcomes.
Okay.
So getting up, making your cup of tea, going to the bathroom yourself, that's also physiotherapy.
Okay.
And culturally, unfortunately, a lot of times we end up, the patients will want a lot of support, a lot of family members to be present. And this is unique to, certain cultures in Asia.
Asia.
Yeah.
That was exactly what I was coming to.
Yeah. So we try to, we don't put a stop to all that because we don't want the patient to feel, we want the patient to feel emotionally well during
not
surgery.
Isolated, basically.
Not isolated, but we also encourage independence.
Okay.
We encourage independence because that really helps.
Willpower really helps.
Really helps.
Okay. So lastly, doctor, can you just give me a kind of, just say 3 points or 4 points to keep your joints, to have a kind of lifestyle where you do not have to go for a joint replacement?
Absolutely, and I think all of us should be talking about that. So there's something you can't control, that's genetics. So we all have a certain genetic programming of wear and tear, and a patient asked me a couple of days ago, can I stop wear and tear? And I gave him the same answer, ask the man above, because that's, as far as I'm concerned, you can't. And I don't know anybody in the world who's been able to stop wear and tear.
Yeah, it's a body, it's going to wear and tear.
Yes, correct. Now what we try and manipulate or play with, for lack of better words, is the slope of wear and tear, how quickly it's going to happen. Now there's an inherent slope that everyone has. That's different for you, that's different for me, that's different for everyone. That's the genetic programming that you have. But lifestyle factors or environmental factors tend to sometimes accelerate that wear and tear. And that's where we advise caution. That's where we advise that there's some leeway in terms of trying to adjust that. For example, body mass index or weight. If weight is very high, that will lead to a higher load on the joints and earlier wear and tear. If there are any injuries from sports or anything of that sort in the younger age, they should be treated and they shouldn't be neglected.
Early detection.
Early detection. If they are neglected, they tend to cause earlier wear and tear. Healthy diet. There's a lot of questions about supplements and all that, but really the evidence is not so strong. A healthy diet is what matters.
No protein shakes?
Protein shakes, yeah, let's not get there.
Okay.
Yeah. So Yeah.
Many will be disappointed if you say
I
you
know,
can't.
I know, and I need to catch a flight later tonight. I don't want to be ambushed outside here later. So,
Okay.
so I think, a diet that is as healthy, balanced, as natural as possible, control of body weight. There's increasing evidence of things like, okay, so if someone's on steroids and things like that, of course, those things are a separate discussion. Again, smoking, alcohol, these things do directly or indirectly affect joint health. But basically, good diet, exercise. You need to load your joints and bone. If you don't load your bone, osteoporosis will accelerate. Treating injuries early, and basics, keeping the basics right. If there's a problem, not running away from the problem. If joint pain is there, often we have patients who come, saying, look, I have joint pain, I have this, I have that. You show the X-ray, there's no space left in the knee, but they'll tell you upfront, I'm not having surgery.
Okay.
So you've already closed the door before you even start the journey. So keeping the options open. Dr. Google's a good one, and Dr. Google, a lot of family members may play doctor, there's a lot of these things. But what I'm trying to get at is getting the right information. Decisions made in ignorance or with a lot of assumptions, comparing someone else's recovery with yours, those decisions usually are not grounded on facts.
Okay.
So getting the right information, being objective about it, and understanding your situation or that individual situation will help.
Okay.
Yeah.
All right. Thank you, doctor. Thank you for your time.
Thank you.
Thank you for speaking to India TV Digital.
Thank you.